Hello, everybody, and thank you for your patience. My name is Sasha. I will be your co-host today for the webinar. I wanted to get started here, so thank you so much for joining. I am going to introduce you to Dr. Palvia, who will give you a little bit about himself and then just dive right into the webinar. So today's webinar is based on Regenerative Medicine 101. Thank you for taking the time to fill out the poll. We'll dive into a lot of exciting things here. With that said, I will pass it over to Dr. Tanuj Palvia, who is our in-house non-surgical spine and sports medicine doctor. Over to you, Dr. Palvia.
Thank you, Sacha. Hopefully you can hear and see me, everyone. What's going on, everybody? Thank you for attending today. Looks like some people are trickling in, but we'll go ahead and get started. All right. So again, I'm Dr. Tanuj Palvia. I'm a interventional non-surgical regenerative orthopedist is the full title. But basically, my focus is I treat patients with sports injuries, spine problems, joint problems, basically problems from head to toe. And one of my major interests is applying regenerative techniques to assist patients with basically recovering from their injuries and leading a pain-free lifestyle. Let's advance the slide. Yeah, so just a little bit about my background again. I studied electrical engineering at Cornell University many years ago now. I've always been a student of the sciences. I excelled in math and science growing up, and my interest took me in that direction. For me, it's always how things work and how can we optimize things. It started with machines and electronics and then moved over into more the biological area. I attended medical school at UNC. And from there, I became very interested in optimizing pain, really in stressful settings. And that's exactly what anesthesiology is. Anesthesiology is optimizing your body's defenses and protecting from surgical insult and pain during that stressful time, and how to get a patient safely through that is one of, in my opinion, a very one of the most impressive engineering feats that humans have developed. So I gravitated towards that through my medical training, and then that translated over to treating patients who have pain all the time. So chronic pain is it's similar in principle, but vastly different in terms of how you treat that. And so that's where my interest sort of progressed towards or evolved. After that, I actually, so that led me into a formal education fellowship program at NYU. I did all my training at NYU, and then I achieved board certification both in anesthesiology as well as interventional pain management, which is, the doctors who are highly specialized in treating chronic pain. After that, the education doesn't stop. I became very interested in regenerative medicine because not only do you want to treat pain, but you want to keep patients out of pain and obviously try to avoid surgical scenarios. That's usually what most patients are looking to do. I think all patients, and I'm going to talk about that, my views on surgery. But I think regenerative medicine is one of the most amazing fields and exciting fields at the forefront of treating pain. And it's beneficial both from a remedial standpoint for injuries as well as prevention. I joined Regenexx, which is a organization of physicians all over the country, actually all over the world. And we are a team of about 70 doctors that are using evidence to treat patients from a regenerative standpoint. And I'm going to get more into that in a minute. What is physiologic? Physiologic is a very amazing practice. Of course, I'm biased, but a very amazing practice that I work at in downtown Brooklyn. For those of you from the New York area, we are a stone's throw over the Brooklyn Bridge, right in the epicenter of downtown Brooklyn. We are a multi-specialty clinic. We've been around for 20 years. And what makes us unique is we are really trying to identify, rather than applying sort of a generic program to cope with your injury, we are really trying to explore and identify what is the underlying cause of your pain and dysfunction. I think that's what sets us apart. And so our plans are really personalized in terms of how can we achieve healing for you and help you achieve your goals. Everyone's goals are different in terms of what is recovery. And so our major goal is to really try to help you accomplish those goals. And then once you do accomplish them, maintaining that healthy, pain-free lifestyle, that's what we're after. And that really gives us the background of why are we here. I am a student of traditional medicine. I did go to an allopathic medical school. I am a medical doctor, but we all of us, doctors included, know that conventional medicine doesn't give all the solutions. Of course, conventional medicine is very important, but clearly all the problems have not been solved. They are, especially orthopedics pain management. Pain is something that afflicts people all over the country and all over the world. And in our country, 126 million people have suffered from pain just in the last 3 months. 40 million have daily pain, and 20 million basically are incapacitated by pain. They cannot work. They have severe limitations. And those are the patients that we really want to help. One major component of that is arthritis. Arthritis is probably the most common problem amongst folks dealing with chronic pain, and it's a major cause of disability in the United States, affecting over 30 million Americans. It's a leading cause of work disability, and it's every year you have increasing cases of surgery. Every year 600,000 Americans get knee replacements. Is that the solution to knee pain? Not sure, but that number is only rising, projected to be 3 million by 2030. The standard therapies to this, the conventional orthopedic wisdom for treating injuries to the musculoskeletal system, whether it includes tendons, ligaments, muscles, joint, and bone, are the following: opioid narcotics, which we know can present its own set of problems. The opioid epidemic, which has plagued our population for so many years, that is obviously an increasing problem and not providing the solutions that we're looking for. Anti-inflammatories, sure, these are effective, but not in a chronic setting. And same goes for some of these other things: cortisone injections, ablations, nerve blocks, things like that. There's a role in place for them, but that's not really providing a solution long term. And same goes for surgery. Surgery, obviously, it's not the wrong answer. I always say surgery is not the wrong answer, but it should be the last answer. And a lot of times it's not the last answer. Knee replacements are becoming more and more common, but it's not something as simple as an in and out situation. And this diagram is a little bit graphic, but that is what a knee replacement looks like. It's basically an amputation of the knee. And then installing a piece of hardware, basically, metal in the body to sort of serve as this organ, your knee. But the results aren't always promising. The results can be mediocre. I've seen stats where about 45 to 55% of knee replacements basically leave patients in the same amount of pain, if not more. That's a huge problem. This is not the only solution. Sometimes it's a home run, but it's not always. And then what do? You're kind of stuck with that. And sometimes the problem can even be worse afterwards. Other problems with surgery, for example, again, in the knee, meniscus surgery actually is just shaving down the padding. That meniscus is that shock absorber between the two bones. Literally a meniscus surgery, if it's a repair, a lot of times that's successful, but more often than not, the surgeon really just goes in and shaves that down. Great, now you got a shaved down meniscus, it works for a couple of years, but then now you have less padding overall. So that actually leaves you at a higher risk for degeneration. Same goes for ACL repairs, joint replacements I've already been over, and in the back, for example, back or spine surgery can often be ineffective. And if there's a fusion that occurs, which means you're stabilizing those two vertebrae by hardware, essentially, you're putting more stress on other segments of the spine, and that can just present more problems down the road, or as I like to say, kicking the can further down the curb. So we need a better strategy, safer strategies. And this is where the field of non-surgical regenerative orthopedics comes into play. What exactly is interventional non-surgical regenerative orthopedics? It is a mouthful, but basically describes a field that is innovative, using natural means, and a very highly successful alternative to the traditional model that I just presented to you. We can use this to target all kinds of injuries or chronic pain, chronic degenerative conditions. And what we're doing is we're using a tissue preservation strategy. And that's accomplished by using the body's own healing cells, which oftentimes I call orthobiologics, to restore functionality and strengthen damaged or injured tissue. And this can involve, what are orthobiologics? Substances that are in your own system. So for example, platelets, which are the healing cells in your bloodstream, or growth factors, or even stem cells, often called that are derived from your bone marrow. Sorry, I can hear, there's a siren outside. That's Brooklyn for you. I hope you guys can still hear me. Essentially, bone marrow is where your stem cells, mesenchymal stem cells, which are important for tissue repair and regeneration, those come from your own body. And so using that under exact imaging to deliver those to site of injuries, that's what interventional non-surgical regenerative orthopedics is is using your own orthobiologics to promote that natural healing cycle. Regenexx is basically, as I told you earlier, is a group of MDs all over the country. We're all doctors, physicians, and we are using what's called precise percutaneous placement. In other words, under imaging, like if I'm treating your knee and you have an ACL tear, I want to make sure those stem cells wind up in your ACL, not just dumping them in the knee, which unfortunately oftentimes occurs. And that's the wrong strategy, because you really want to deliver these precious orthobiologics to the actual site of the injury, to the millimeter. And that's what interventional orthopedics is using that image guidance. And Regenexx, as a group of physicians, we pool our data. So we have over 40,000 patients that we've treated over the last 15 years. And we are compiling evidence to basically show what works, what doesn't work. This doesn't work for all scenarios. That's something you also need to know is, are you a good candidate? And I'm going to get into that going forward. And then we also record our results. So we have the largest database in the world of regenerative treatments. We call it our registry. And what we do here is we store our patient outcomes and also opine on what are the least invasive solutions backed on that research that we've compiled from that registry. So very, very important. It's an evidence-based approach. And at Physiologic, what we're doing, again, is we're providing that unique plan for you. It's a phasic model of optimized health and healing. There's no generalized playbook here. Of course, there are certain things that everyone should be doing: avoiding degenerative influences, optimizing the body's healing environment. That includes your nutrition, your physical activity, your mechanics, what kind of exercise program you're doing, what is your, even things such as your metabolic activity. Are you pre-diabetic? Do you have a high blood pressure? All of these things affect the quality of your cells that we're using to treat you. So we want to optimize that before we even begin that repair process for you. And once we optimize that, then we can actually present these treatments to you, whether it is stem cell treatment or PRP treatment, again, what I call orthobiologics, which are then introduced to that site of injury to promote regeneration. And then we nurture that regeneration, that healing process, strengthening, correction, so on and so forth. And once you do hit your goals, we want to keep those goals. So we want to promote that state of wellness. And the goal is to reverse chronic disease, or at least deteriorate as much as, decelerate that deteriorative process as much as we can. That's the goal at Physiologic and what we're trying to accomplish for our patients. And again, I've touched on this already, but how are we different? We're a multi-specialty process. Interventional orthopedics describes image-based treatment. So everything is done very, very precisely. This is a picture of my treatment room over here, one of my treatment rooms. And you can see a picture of my x-ray. So everything is done under x-ray. Off to the side, there is an ultrasound machine. It's not pictured here, but to explain to you, everything is done very, very precisely. And then that's integrated with your rehabilitation program. Most problems have some underlying mechanical issue that has to be addressed. It's not just an injury. These are not magic cells that basically heal something, and nothing else needs to be done. Whatever deteriorative influences, whether it's from, postural, mechanical, whatever it is, that has to be corrected. And so that integration of rehab is super important to really achieve those results. And then we have other programs like functional medicine, nutritional optimization, wellness, and prevention, again, to basically increase your overall wellness state. The health of your cell, your body is what's going to really achieve those results. Our patients range from all over, whether it's pro athletes to our weekend warriors, to elderly patients, to just the average person who's trying to complete their fitness program. All of those patients come to Physiologic. So is interventional non-surgical regenerative orthopedics right for you? That all depends on the old school, your evaluation. So one really important point, a lot of times I get a question, Doc, my MRI shows a meniscal tear. Am I a candidate? Well, that means a lot of things. Most patients don't even, most people don't realize there's a study recently published. 51% of people walking around over age 50 are walking around with meniscal tears that they don't even know about. So is that clinically relevant? Does that need to be treated? That all depends on your evaluation. So when I see patients, I want to know everything from A to Z. What happened from day one? How did that pain start? What's been going on? What degenerative influences were there? Was there an injury? And that all comes from your history and physical exam. So just like any old school doctor's visit, I need to see what's going on. We need to have a full evaluation where I'm basically looking at everything. A lot of that is in imaging, so MRIs are important. It gives us a photograph of what's going on, but it doesn't tell us everything. For example, if I get an MRI, that's a picture of you laying in a tube, but that doesn't tell me anything about when you're standing or sitting or running. So a lot of time I complement that with an ultrasound exam. So ultrasound exams I do on site, and that gives me more live data of what's happening. So what happens when you do bend your knee? What happens with the swelling? Where does that move? Or with your shoulder or hip or whatever it is. That functional assessment is very, very important, and that comes from your evaluation. So I encourage all of you out there who are listening that you cannot give advice off of just an MRI. Of course, MRIs are very, very important, and they give us great, valuable information. But to make a decision on such a critical matter as to how to treat an injury cannot occur just from an MRI. So very, very important point for those of you listening there. Whether you treat with me or anybody else, it's very, very important that your doctor is doing a full assessment of what's going on. And then, I also want to know what have you done so far? What's worked? What hasn't worked? Have you taken any medication? Have you done any physical therapy? What kind of prevention or protection are you using, including bracing? What kind of lab work have you done? Or do you have low platelet count? So, for example, will that be a problem when I treat you? Or do you have elevated sugars? Are you diabetic? Is that preventing your ability to heal? All of those things are super important to assess when you're trying to figure out how to approach your injury. And then basically in that assessment, then we determine where you are. Is this something acute? Do I have to put the fire out, right? So that's what this diagram shows. Is this like if you come into me and you have a swollen ankle, that's not the time to initiate repair. We just got to get that problem under control. So is that an acute situation where I just need to provide relief? Or we look and actually correct and start strengthening? So that assessment is very, very important and determines your algorithm of where you need to go. So again, the assessment is super, super important. You can't just give sort of like a bread and butter, here's a playbook and go from there. That often will fail. So what does symptom control look like? Is that going to be a short course of medication or maybe a small dose of cortisone? And, we could talk about cortisone. That's its own topic. And maybe we can do a separate talk on that. Let me know or comment in the chat if you are interested in that alone, because I could go on and on about that. But typically, cortisone is useful for putting out a fire. And if you use it at the correct dose, then it's not harmful. But a lot of times in orthopedics, they're using that generic high-dose cortisone treatment, which then can be very, very detrimental. So that's a discussion that we often have during consultations. Other treatments, gel treatments called viscosupplementation, nerve blocks, even medical marijuana, if you have access to that. These are all very, very useful agents that can help get the problem under control. And alongside that, we need to improve your functionality. So I need to decrease your pain and improve your function. And that a lot of times I lean on my chiropractic physical therapy colleagues here who can help start strengthening the area before we even initiate treatment. And what does that look like? So in a nutshell, and my chiropractic colleagues, I encourage you to seek out some of the information that we have on our website, because that's a whole field on itself. But in general, what is the purpose? Chiropractic is not pop, pop, pop. No one really does that anymore. Chiropractic is more of a functional strategy to assess what is your skeletal health? How are your joints moving? What is your stability? What is your symmetry? How do we promote fascia health? Fascia is basically that sleeve that encases your musculoskeletal system that promotes blood flow to these areas. So how do we minimize restrictions? How do we free up scar tissue? How do we increase blood flow and optimize nerve health? All those things are done in the hand of a good, modern, newer school chiropractic. So very, very important. Physical therapy is just as important too, but that's more of a hands-off, exercise-based strategy. So chiropractic is more hands-on, which is super important if you're dealing especially with a chronic injury. Physical therapy is more hands-off, exercise-based, working on strength, core strength, for example, balance, flexibility, range of motion. All of these are important components of mechanics that have to be addressed when we're trying to get through the problem and assist in your healing. So then that brings us to regenerative medicine. Once it is time to get to the regenerative phase and introduce that orthobiologic side of injury, what does that look like? Well, a little background on that. Regenerative medicine is the area of the medical sciences that investigates the application of cell-based therapies, or as I told you, we call them orthobiologics, to treat damaged areas and initiate repair and regeneration. There's a lot of buzzwords out there. The ones I want to focus on today: prolotherapy or prolozone, platelet-rich plasma or PRP, stem cell therapy, which is its own talk, but in general, the areas we're looking at: bone marrow concentrate, which in my opinion is the most valuable for these types of injuries. There are other tissues like adipose, amniotic, umbilical, which I'm not going to cover in this talk as much because for various reasons, they're not effective for musculoskeletal conditions. whether it's just lack of mesenchymal stem cells, which I'm going to talk about, or the absence of stem cells, which is a lot of these prepared products, amniotic, umbilical, placental, those buzzwords that are out there, that's what it applies to. So what is prolotherapy? Prolotherapy is a dextrose-based solution. Dextrose, what is that? That's an analog of sugar. So in the old days, they used to call it sugar water treatment. And what that is that's basically introducing that to a site of injury to promote some blood flow. It's actually irritating the tissues, so your body sort of starts revving up its own defense mechanisms to start healing an area. It's sort of conceptually similar to homeopathy, but it actually shows that you can start to initiate that site, initiate repair in that site. And by causing that irritation, you're promoting a fresh blood supply to that area. So for example, if you have a tendonitis and I introduce dextrose to that area, and that causes some irritation. So your body sees, okay, there's a little bit of, I need to start revving up my repair response to that area. And it starts to direct blood flow to that area, and you can start to accelerate that healing process. And this can be used for a lot of areas. And, when I describe our whole treatment algorithm, it'll make more sense. Prolo-ozone is combining prolotherapy with ozone. Ozone is a very promising field of its own that we use mainly for musculoskeletal joint issues. Ozone has anti-inflammatory properties. For those of you, from science, if you remember, ozone is basically a hypersaturated oxygen or O3 molecule. And the benefits of ozone include is that it basically strengthens the immune system, it stimulates your leukocytes or your white blood cells, and it prevents infection and immune system deficiency by destroying basically microorganisms. That's how ozone functions. PRP or platelet-rich plasma is basically your platelets. Platelets are the cells in your body that promote healing. So your blood basically has three components: red blood cells, which carry oxygen and iron and so forth. White blood cells, which are your basically the immune soldiers in your body. They are fighting infection, mounting your immune response, etc. And then your platelets. Platelets are what promote healing. The problem, very important concept here, platelets circulate throughout your entire body. So where there is good blood flow, such as with your organs or with your skin, your platelets are constantly healing that area. That's why your skin is so resilient. Most of us have, good skin, unless there's some kind of disorder. Skin basically is able to heal itself. If you get a cut, what happens? It swells up, which is the response from your body, the inflammation. Then you form a scab there. And then that scab basically, once the repair is done, the scab flakes off. And then the inflammation comes down, the swelling, and then you have new skin. Why doesn't that happen in musculoskeletal tissues? That's for two reasons. One, you have poor blood flow in those areas. And two, the tissues are tough. It's not like skin or your organs, which are soft. So that double hit is what causes that process to not go to completion, which then results in chronic inflammation, which is limiting and painful. So the concept behind platelet-rich plasma is if we can do a blood draw, concentrate those platelets so as to increase that blood dose. And with Regenexx, we can do that. We can increase up to 20 times. So you get a very high dose of platelets. Now you can really rev up that inflammation in that site of injury once the platelets are introduced there, and you can promote that healing process. So again, if you do a blood draw, concentrate those platelets, and then introduce that to the site of injury, you can actually complete that healing response. And that is the whole fundamental behind platelet-rich plasma. So think of it sort of like also causing irritation, stimulation, like prolotherapy, but at a much higher level. And then the third orthobiologic are stem cells. And simply put, a stem cell is a cell that can replicate into any cell type. For orthopedics, we use what's called mesenchymal stem cells, which come from your bone marrow. And these are the ones that differentiate into musculoskeletal tissues, which is a sort of the scope of this presentation, whether it's bones, cartilage, tendons, ligaments. These are what we're after for, again, the type of conditions that we're treating. And these mesenchymal stem cells, the subtype of pluripotent stem cells, or the godfather of stem cells, are mesenchymal stem cells, MSCs. Those live in the bone marrow. So bone marrow is what we're after when we're treating, and that's why almost all the treatments that we do come from the bone marrow, and the stem cells living in the bone marrow. So bone marrow aspirated stem cells, or bone marrow aspirated concentrate, or also called BMAC, you may hear that a lot. That is what's used in the scope for regenerative medicine with regards to musculoskeletal injuries. Stem cells live in other areas too, in fat cells, even in amniotic cells or umbilical cells. But the problem there is fat cells don't have that high concentration of mesenchymal stem cells, which are used for orthopedic purposes. And amniotic, umbilical, these sort of derived products, those, because they're prepared usually by a pharmaceutical company, when they are prepared, they're irradiated. So all the stem cells basically die. Essentially, while those products have other things like growth factors, these prepared products are devoid of stem cells, and which is why, and that's basically been fairly well demonstrated in the literature, which is why they are not used for these types of injuries. Our stem cell treatment protocol. So stem cells typically are used for more severe conditions, and the thought process behind that is threefold. Basically, our regenerative treatment protocol is aimed for a three-step process, which is the following. The first step is prolotherapy combined with ozone. And as I told you, that basically is preparing an injured area, increasing blood flow, kind of what's called preparing the site or tilling the soil, if I were to use a metaphor of a garden. Preparing that area so that I can come in on day number 2 and actually introduce the stem cells. And those are your seeds. So the stem cells come from your bone marrow. Once that's prepared on site, then that is introduced to that site of injury. I get a lot, usually here, I get a lot of questions. Well, isn't that painful? It is not painful. As I told you all in the beginning, I'm an anesthesiologist. So all patients, they get some form of typically mild sedation. You are not out because I need to be able to communicate with you. Typically, you're happy. I numb the area, so there is no pain involved with this part of the treatment. And then the third part is PRP treatment. So all stem cell patients on visit number 3, when we determine when that's appropriate, PRP is then, which is comes from a blood draw, as I showed you in a previous diagram. That's also introduced to the site of injury, and that does 2 things. It heals, like that scab. So I'm forming a huge scab to help promote healing, but it also helps stem cells grow. So it almost acts like a fertilizer, and we call this phase of treatment the sun and water treatment, or sun and water phase. And this formula can be used for all kinds of conditions. So this list is not complete, but this is a sample of all of the injuries that can be treated using regenerative modalities. A lot of these, if you see an orthopedist, will also give you a surgical answer, but regenerative modalities can be applied to all these conditions on the screen, but this is not a complete list, but I do encourage anyone watching here to take a screenshot of this. Oh, sorry about that. So just some examples of what these treatments look like. This patient, this is out of a textbook, but just to give you an idea, this is how a treatment into a disc looks. So for people who have degenerative disc disease, regenerative medicine has amazing results here in terms of if you have a disc herniation or an annular tear, which is a tear in a disc. A lot of these can be treated just with PRP. So that's what's listed here. This particular patient is getting treatment into 2 discs, L4-5, L5-S1, which are the 2 bottom, the lowermost discs of the spine. And here, this is an MRI from our registry. So this is a patient who had a very large herniation at L4-5. By the way, what is a herniation? That's also called a slip disc or a bulging disc. This diagram, just to kind of break it down, this is the front of the spine, this is the back of the spine. And so this is the spinal cord. I hope you guys can see my mouse there. But this is the spinal cord. So when a disc slips, it ends up pinching the spinal cord like that. So these nerves that come out, they look like little strands of hair. They go down your leg. So this can often present as very painful pain starting in the back and shooting down the leg, also called sciatica. So this is a patient that actually received PRP into the disc, very high dose, 20 times concentrated PRP, platelet-rich plasma. This patient did not need stem cells, and you can see near complete resolution. This is an MRI 6 months out, showing almost all resolution of this disc. So this is the same patient. This is a picture from the REGENXBIO registry. Here's a treatment of an ACL repair. So this has really transformed my practice. Patients who have ACL tears, partial tears do really well. Even complete tears can do very well here, because a lot of times there are some strands that are intact, and stem cells can provide a means to basically repair both ends of the ACL. So this is a patient getting basically an ACL repair using a needle-based therapy. I think this next slide, yeah, this is again imaging from our registry. This is a patient that has an ACL tear, and again, approximately 6 months out, you can see near complete resolution of that ACL. And I'm treating patients very frequently for this, and the results are outstanding. This is a shoulder. This is a rotator cuff tear here. Again, a picture from our registry. This is a tear. Typically patients with less than 1 centimeter tear. This is the supraspinatus tendon, which is one of the tendons of the rotator cuff. Again, with bone marrow, BMAC, or stem cells, as we say, you can get great results as long as the tear is not, usually after greater than 1 centimeter. A lot of times those patients won't respond, but 1 centimeter or less, certainly partial tears, these patients do very, very well. And this is just usually for shoulders. We also want to use ultrasound guidance to confirm placement. So you can see the same. This is sort of how it's introduced. Obviously, this is a stock photo, but this is from our registry, a patient getting a treatment into the rotator cuff. You can see the needle coming in like this and depositing orthobiologics at the rotator cuff. All right. Almost there. Thank you for those of you who are still with me. I got a couple examples I want to go through. These are real patients that have been treated in my clinic. The first patient is a 41-year-old busy mom, Pilates instructor, presenting with hip pain. The MRI showed basically labral degeneration. Labrum is that tissue that surrounds the socket part of the hip. So the hip is a ball and socket joint where your thigh connects to your pelvis. And around that socket, there's a layer of cartilage called the labrum that sort of acts like a gasket and grips I don't know if you guys can see me here, but sort of grips that the top of the thigh bone called the femur into place. And that doesn't have to tear. It can just degenerate from wear and tear, especially, someone like a Pilates instructor who is really putting a lot of force on that hip. So she underwent right labrum PRP treatment. Again, PRP is healing. I don't necessarily need to regenerate. I just want to reinforce, tighten down that tissue. So in her case, that degeneration, I just wanted to tighten down. And this was done with a combination of ultrasound and fluoroscopy, which is that X-ray machine. This patient did very well, 3 months out, near 90% of recovery, 2 years out, full resolution. In fact, we recently treated her left hip almost preventatively because that was starting to feel a little funky. And we determined that getting in front of any labral degeneration would be the right move. And she is back in action doing full-time Pilates instruction. Our second patient, a little bit older, a little bit less athletic, but still very active, constantly on her feet, 56-year-old female dealing with basically rolled ankles all of her life. She'd already undergone 2 corrective orthopedic surgeries for those ankles when she saw me. Again, what causes ankle rolling? So ankles basically are supported by ligaments. Ligaments are straps that hold bones together. So where the bottom of your shin bone meets the top of your heel, there's basically sets of ligaments on either side. That ball on either side of your ankle, that's supported by a ligament complex. And those ligaments get loose over time, especially if you keep rolling. So what's supposed to be tight like duct tape basically ends up becoming loose rubber bands. So again, platelet-rich plasma, good for healing, good for tightening these ligaments, basically sort of healing that deterioration. That's what PRP is for. So for this patient, she underwent for both ankles under ultrasound PRP treatment. For her, it took a little bit longer, 5 months out, complete resolution of pain, significant recovery. This patient I treated, I want to say before COVID. So, and I still see her for other issues, but her ankles have been great. Of note, I included her because her surgeon gave me a call and wanted to know what I did to prevent the mushiness of her ankles. And the answer to that is PRP treatment. Patient number 3 is a little bit older, a little bit a little bit less healthier, 61-year-old construction worker, but still working full-time, very active job, on his knees a lot, dealing with severe arthritis of the right knee. Arthritis means loss of cartilage. So this patient had basically lost all the cartilage in his knee, and that impacted the knee's range of motion, impacted him from a pain and functionality standpoint. When I first saw him, his knee was completely swollen, so he was in that acute phase. I had to walk him through that before I initiated that treatment. He was also overweight, dealing with blood pressure and diabetes. So this patient required some optimization pre-treatment. I had to get his sugars under control, his blood pressure under control. We had to work on weight management, both from a activity standpoint as well as a nutritional standpoint, focused on nutritional intake to decrease the overall inflammatory state of his body before we initiate any kind of treatment. For him, we went for a more powerful orthobiologic called stem cells, as we discussed, also known as BMAC, and he had a bit of a protracted course. So we treated him last summer. In first 2 weeks were very bumpy because there was already inflammation that we had to deal with. And you can see here, I sort of recorded his progress. Every time I see you after your treatment, I'm recording how much improvement. And really 4 months out, he'd only had 16% improvement. So what we did is we doubled down on his rehabilitation, the functional deficits that he had before, and really got in there with my chiropractors to work out a lot of that scar tissue that had developed over time. And it really wasn't until about 6 months, 6 to 9 months, where he started seeing some real improvement. So a lot of times this can be a slow burn. This may not be a completely, accelerated or fast, quick solution, but nonetheless, we successfully treated him. He was up against a knee replacement, and that is something that, right now he's basically completely out of pain, back to work. And, at this point, it doesn't look like he'll ever need surgery. Our last patient, just want to include, for completion's sake, this is a near 50-year-old skier, very active patient who continues to remain active, cannot get him to slow down at all, dealing with both degenerative disc disease and basically problems with Achilles tendons, constant back pain with activity, pain shooting to both legs, sciatica, as I told you. And again, another talk in itself, but that can have an indirect and or direct effect on the Achilles. So if you have a dysfunctional nerve in your back that innervates your Achilles, and your Achilles is going to be dysfunctional, that's kind of the short of it. So this patient was dealing with chronic Achilles tendon problems. He had failed several conventional treatments with other doctors. So for him, we used a more aggressive approach against, stem cell treatments. For him, we put it in his disc to try to actually reinflate that disc and get some of that herniation to pull in and heal some of the tearing in his disc, as well as PRP to the joints to stabilize, again, tighten up his spinal column, because a lot of spine problems can come from instability. And we also did PRP to both ankles, particularly the Achilles, to tighten up those tendons. This patient also had to undergo rehabilitation. And 4 months later, his back is doing exceptionally well, about 85 to 90% improvement. He's back in the gym, planning to ski this season. So those are just 4 good examples, but definitely not including all of the different applications of regenerative medicine. I hope you found that I hope you found that informative. Feel free, we're here to answer all of your questions. Here's our contact information here. I really want you to have a good understanding, foundational representation of what is regenerative medicine. There's so much information out there, and it's important to know what is effective, what is real, what is not real, what is truth, what is not truth, etc. Again, our contact information here. This is our phone number, email if you want to schedule a consultation. If you have any follow-up questions here, there's some fun stuff. My Instagram account, our practices Instagram accounts are up here, so you can see what's going on. We're constantly putting updates there of what's going on in terms of new treatments we're doing, or how patients are moving along. My link tree, just to see some more fun stuff about me. And then our contact information if you want to learn more about what regenerative medicine looks like at Physiologic. And that's it. We're ready for some questions. I'm going to leave the contact information on the screen, and I will turn it back over to you, Satya.
Thank you, Dr. Palvia. Thank you to all that have joined today. Again, if you have questions, please put them in the chat box, or there is an actual Q&A button. If you are on your phone or on your screen, you can see it all the way down towards the bottom. I do have a couple of questions that have come through. Let's begin. Can regenerative medicine techniques such as PRP and bone marrow concentrate offer relief for chronic tendonitis conditions like tennis elbow or Achilles tendonitis?
Absolutely. Great question, whoever asked that. In fact, regenerative medicine, the first cases that were done way back in the early 2000s were for those 2 conditions. Achilles tendonitis or tendinopathy. Achilles tendon is what straps your calf down to your heel. So that's a huge tendon in the back of one of the largest tendons in the body. So again, for those of you listening, a tendon is what straps a muscle down to a bone. And the very earliest cases of PRP done in the early 2000s, actually overseas, since our European counterparts tend to be a little bit ahead of us, there was demonstrated efficacy for Achilles tendinopathy, Achilles tendon basically, and lateral epicondylitis, aka common extensor tendonitis, or tears, aka tennis elbow. So that's basically right here where the common extensor tendon, the muscles here, strap down to the elbow on the outside of your elbow. So the first cases that were demonstrated to respond to platelet-rich plasma were for those conditions. And so the evidence is, I would say at this point, level 1. In fact, there's many physicians out there who only will do platelet-rich plasma. Old school orthopedics will still try to recommend doing cortisone shots for that, which again, as I said, Sacha, we should probably do a cortisone lecture, but cortisone, can actually damage tendons. So there's many doctors who will hesitate to give cortisone, at least at its standard dose. At micro doses, there's still some benefit, but overall cortisone is fairly debunked for those conditions. To answer your question, BMAC versus PRP, that depends on the nature of injury. So for a mild tendinitis means an inflamed tendon, or tendinopathy means a tendon that's not torn, but kind of beat up. Think of like a rope that's either, instead of torn, it's frayed, or even for a partial tear, PRP, platelet-rich plasma, can work really well for that. If it's a more severe tear or a complete tear that's even retracted, less than 1 centimeter typically, then stem cells, basically more severe condition, is what would be recommended.
Awesome. Thank you, Dr. Pavia. Another question that just came through: would someone that is on a blood thinner be a candidate?
Yes. So great question. Blood thinners. The problem with blood thinners is, depending on where you're working, there's a propensity for bleeding. So depending on where you're working, the amount of work we're doing, we may need to hold the blood thinners, but we treat many patients who are on blood thinners. Basically, whoever's the prescribing doctor, I typically will reach out to them and make sure we have a good game plan for holding that blood thinner if necessary. It's not always necessary. Some of the superficial treatments don't require holding blood thinners, but if you're working in deeper structures, particularly the spine, if we're working around some of those deeper nerves or the spinal cord or in a disc, then we'll have to develop a strategy to hold those blood thinners. And we treated a patient last week where basically I was coordinating with the cardiologist to hold that patient's blood thinners. Depending on the blood thinner, there's so many blood thinners out there, so every blood thinner is different. And if your cardiologist and myself, if we determine that it's appropriate to hold that, given the risk-benefit analysis, then we will work with you on holding that and then resuming that in the appropriate time interval that's recommended.
Perfect. On to the next question. How effective are Regenexx procedures in treating chronic lower back pain? And how do they compare to other conventional treatments like steroid injections or surgery? Well, we talked about the surgery, but the steroid injection, I think, is an interesting one.
Yeah. So, again, steroid treatments for back problems have been around for 40 plus years. Again, steroid, you have to be very careful. Steroid gets a bad rap sometimes. I don't think they're completely inappropriate, but you have to be careful with cortisone, which is a synonym for steroids. You have to be very careful with using those. And also dosing them at high dose. There are some risks with decreasing bone density or depleting cartilage in an area or degrading soft tissue such as ligaments and tendons. So, I'm very, very wary of patients who tell me that, they go to their doctor and they do cortisone shots in their back every 3 months. I think that's not a good strategy. Cortisone is a fire extinguisher. It's like a fire hose. That slide I showed you of the house on fire, it's effective for putting a fire out. So if dosed appropriately and the risk-benefit analysis done with the patient, I think cortisone I like to do what's called nanocortisone dosing, very tiny dose. I think that can be safely administered for the purpose of putting out a fire. But cortisone treatment in the back for long-term, I think is there's very diminishing returns on that. And I advise patients to be very, very cautious about going down a road where you're doing cortisone treatment every 3 months, because you're just basically putting a fire out, but you're not addressing the underlying problem. And if that underlying problem is unaddressed, you're going to be in this cycle where the problem comes back and you keep spraying down these areas with cortisone, which can over repeated use can be toxic. So regenerative medicine, on the other hand, is actually trying to strengthen an area. So for example, PRP, platelet-rich plasma, is very effective in the back. Particularly the spinal column. The spine is a stack of bones. I like to compare it to like a Jenga tower. If any of you guys know that game Jenga, where you're trying to stack the blocks up, that the way the blocks fit into place and the stability of that is what's going to determine its fate in terms of if it's going to topple over or not. The same concept applies to the spine. The spine is a column of vertebrae, and stabilizing that vertebrae is what's important for securing its longevity and decelerating its deterioration. That cortisone can't do it all. That's where things like platelets, which can heal and tighten down those ligaments that support the spine, I think that's a very effective strategy for nurturing the spine and strengthening it down the road. What does a surgeon do? A surgeon basically goes in and puts bolts and screws to try to secure that Jenga tower. So conceptually that makes sense, but there's problems with that. Obviously it's risky, and there's a lot of times there's problems with the hardware, so there can be long-term issues. And then the biggest problem is what's called adjacent level diseases. Sure, you've secured that part of the spine, but now the above levels are still seeing stress because they've not been secured. So invariably what happens after a spine surgery is patients end up needing to get more and more levels fused, which means more hardware, which means more risk, more potential hardware issues, less mobility, and a higher risk for disability, essentially. So I hope that answered that question. Cortisone versus platelet-rich plasma, orthobiologics versus even surgery, and how you should be approaching that.
Thank you, Dr. Pavia. A follow-up question from our attendee that asked about the blood thinners. Blood workup and any testing is done at Brooklyn site only. Can the patient have the blood work or testing done on their own and bring it in?
Absolutely. Most of the time we don't have a lab on site. So we work with areas with blood labs in the area, or, if you've had recent work done, we work with your primary care doctor. Usually if you have a good doctor who's doing screening, typically I have most of the data I need. Again, it depends on what you're dealing with. Some of my patients who might be a little bit sicker or who have some chronic conditions, managing a lot of that, sometimes we have to investigate a little more. So we certainly, can send you to your preferred area to do that analysis. We work with your primary doctor. A lot of times our patients have that information already, so certainly want to avoid any redundancy there.
And then last follow-up from the same attendee, does the patient have to use your chiropractor and PT facility?
Absolutely not. I mean, this is everything's elective, right? So I would say you don't have to do anything. One thing you want to do is, if you're electing to use an outside, we have patients who come from all over the country. So a lot of times they'll come and do the treatment with me, and then they'll do the rehab. Can be a long-term situation, 8 weeks, 12 weeks, whatever. So we usually work in conjunction with their outside facility and try to guide them in terms of what makes sense from a regenerative standpoint. Post-regenerative physical therapy chiropractic may not be the same as your conventional physical therapy or post-surgical physical therapy, because it's more functional. I want you rehabbing while this healing is occurring with this type of treatment. So a lot of times, it makes sense to work with a practitioner who's familiar with that. Some physical therapists may not understand what is the purpose of doing PRP in the spine. It's a fairly new field. I mean, it's been about 15 or 20 years, but it's really only become mainstream in the last 5 years. So unless you're working with someone who's familiar with the newest and latest research, they may not necessarily apply the correct techniques and principles that'll optimize your rehabilitation. We certainly try to work with your outside providers. We try to give them our instruction, our playbook as we use here. But sometimes that doesn't necessarily work out for the best. That's not to say that there's amazing physical therapy facilities. Obviously I'm biased, so I'm going to say ours is awesome, but there are plenty of awesome providers out there. And we certainly, if to make your life easier, if we need to work with them, we can do that for you. But I always advise patients to understand that it may, that whoever they're working with, that their team understands what our goals are.
Thank you for that, Dr. Pavia. Next up is for patients with chronic issues in smaller joints, such as the wrist and hand, due to conditions like carpal tunnel syndrome or arthritis. What options does regenerative medicine provide, and what has been the observed results?
So regenerative medicine, as I said, can be applied to all over the body. It doesn't have to be the major joints. So I'm putting this slide back up on the screen. We frequently treat wrist issues, common conditions. Wrist arthritis, carpal tunnel is a big one. Many people suffer from carpal tunnel syndrome, TFCC tears, ligamentous injury, even fractures you can treat with regenerative medicine. So wrists certainly fall under the category. And again, it depends on the severity. So milder conditions, soft tissue injuries such as tendonitis or ligamentous injuries, usually we are using PRP, platelet-rich plasma, for that. For more severe conditions, arthritic conditions, depending on the severity, I'll recommend bone marrow aspirate, BMAC, or stem cell treatment. One area that I didn't really expound on in this lecture is treating nerves. So carpal tunnel is an entrapment of the median nerve. Median nerve is basically that nerve that travels under this sheath here that kind of straps everything down. And so that nerve becomes irritated. So a lot of times what we use something called platelet lysate. Platelet lysate essentially is taking your platelets and breaking them open. And what that does is that releases a lot of growth factors that can help treat nerve entrapment. So nerve entrapment, like for example, a pinched nerve in the spine or a carpal tunnel situation where the median nerve is entrapped, those respond really well to platelet lysate, which is sort of an advanced form of PRP. And so to answer your question, there definitely are many applications of orthobiologics to conditions with the wrist and the hand.
Thank you so much, Dr. Palvia. I have one last question. How have regenerative procedures been used to address chronic ankle instability or recurring sprains?
So I had that example in the cases that I gave at the end, and again you can see on the screen here. Ankle is a major joint, just like the wrist, just like the knee, shoulder, etc. Same type of concepts: cartilage, ligaments, tendons, nerves, basically all control the ankle. So all of these modalities apply to the ankle as well. Again, like I think they asked about rolling particularly. Rolling refers to typically it's side rolling, medial or lateral rolling, and that involves the ligaments on either side of the ankle, and those become loose over time. So unless it's a severe tear, generally we're doing PRP for those, and that's what's recommended for ligamentous injuries of the ankle. Obviously, there's no one size fits all here. It depends on the amount of pain that you're in and the amount of functional limitation and what kind of injury what kind of injury the imaging shows. So to answer your question, ankle treatments certainly fall under the category of conditions that are addressed by regenerative modalities, including PRP and or stem cells.
Okay, great. Thank you so much. I think we have concluded the questions unless there are any last minute questions. If you do have them, please plop them in the Q&A bucket. But we wanted to give a special offer to the attendees. And if you schedule within the next 24 hours, our typical 300 evaluation will be offered at $87, plus any additional 10% off any regenerative medicine that you need to be doing thereafter. So definitely go ahead. And Dr. Palvia, if you want to put up the screen that has the phone number and the email.
Okay.
I've also put it in the chat. But if you all would like to take a photo of the screen so that you can take advantage of the offer to come in and meet us, see our facility, meet Dr. Palvia in person, you can call us at the 646-328-6126 and then or email regenxcc@physiologicnyc.com. And again, please go ahead and follow Dr. Palvia's Instagram account, our Instagram account. If you have any questions, I'm sure you can DM him or send us an email, and we hope to see you guys in the office.
I just want to add again, thank you all for attending. I hope you found this informative. Make sure you do your homework if you're thinking about doing regenerative treatments. And then the other thing I'd like to add is we give these talks fairly recurrently. So if there's any specific topic that you're interested in, please email us. We certainly would like to delve more into that as we sort of go into this recurrent series. So please reach out to us if there's any questions or a topic you're interested in. We certainly would like to deliver that information to you.
Thank you, Dr. Palvia, and thank you for all that attended today. And we look forward to seeing you on our next webinar, or as I said, in the office. Take care, everybody.
Thanks, everyone. Have a great day.